Welcome to the PeakDay podcast, where we talk about fertility and natural family planning with our friends. Today's guest is Megan Blum. Megan is a physician assistant with a special interest in providing restorative reproductive care to women of all ages. She has special training in FEM and Marquette method and is a medical consultant for both models of women's healthcare. She became a medical provider to help provide access to fertility awareness-based medicine to all who seek it. She believes in finding the root cause of women's health and endocrine issues to restore women's body to optimum health. Megan has a special interest in premature traumatic birth and using NFP after a traumatic birth. Megan teaches several courses about women's health with Betsy Hoyt at Integrated Catholic Woman, and you can find her writings on the My Catholic Doctor blog. Megan and her husband have 3 young daughters and a new baby boy. Thank you, Megan, for joining us on the PeakDay podcast.
Thank you so much for having me.
And congratulations on your new baby boy with you. But let's start from the beginning. When was your interest in reproductive medicine kindled?
Great question. I knew I always wanted to practice medicine ever since probably middle school. I was interested in different fields, and later on, I think I just got an interest in women's health. And really during my conversion to Catholicism in undergraduate studies, I was reading different documents and reading the church's teaching on women and about NFP, and I was taking some NAPRO classes to learn about NFP or Creighton just to kind of see what it was like. And I really feel like it kind of lit this fire for me to practice authentic women's healthcare. And what did that even look like? Did people practice that way? So really my conversion, I think, just like I said, set those sparks for me. And I really pursued it all through undergraduate as well as, in my graduate studies at PA school. I told everybody I wanted to go into women's health. Everyone thought I was slightly crazy for the way I wanted to practice. And we got married in PA school, my husband and I, and we actually found out we were unexpectedly expecting during my PA studies. So it really was kind of a time to live by my own convictions, if you will, and kind of be a witness to the type of women's health I wanted to provide, the kind that's open to life and kind of whole person and whole woman affirming. So that was really beautiful to be able to witness that to my colleagues in PA school. And I really just told everybody this is what I wanted to practice. And finally, through my Catholic doctor, I was really able to take a chance and practice it, which has been a huge blessing.
Okay. So when you were and your husband were engaged, did you learn about natural family planning at that point as well? Or, how did the NFP thing come into your marriage?
Sure. So I had already in undergraduate school, I had already taken kind of the intro Creighton class and was charting, was comfortable, was really close to my fertility practitioner as far as learning Creighton. So I was ready to go. And then my husband and I took classes with her, a couple of times before our marriage. We were very comfortable with using it. I was comfortable with, being married halfway through PA school and having the faith to practice NFP, whereas a lot of my colleagues just were very against having children during their studies, the ones that were married. So we're taking measures, that are standard to kind of secular medicine to kind of prevent that. So, but yes, we were very comfortable with NFP and God still, blessed us unexpectedly with our first daughter.
So how was it for you to know that you had the support of your husband to be able to practice natural family planning in your marriage?
Yes, that is such a great question. I feel like I had a lot of freedom just to really lean into that. And I feel very grateful that from the beginning, he comes from a family of 6 boys. So he kind of had that example growing up of being open to life and being open if God wants to send you a big family. And from our get-go, he was really supportive of that while also, realizing that I had a call to practice medicine. And we were just really open to see what God wanted from us. Did He want us to
Mhm.
have a big family? Obviously, kids right away, and we've got 4 now. So
Yeah.
I really feel like it made a big, I don't know. It just feels like a huge gift that He gave me to really not have to worry
Mhm.
about, oh, well, He would only like 2 children, and that means we really need to
Yeah.
have a lot of anxiety about NFP and really be, on top of it and that kind of thing.
Mhm. Mhm. So you mentioned you have 4 children.
Yes.
And I believe that you, at least one of those was a traumatic birth. Can you tell us a little bit about that and maybe about using natural family planning after that?
Sure. So we have 3 girls and a boy. And so our third girl, we found out at my 20-week ultrasound that I had a placenta previa, so a complete previa. That's where the placenta covers your cervix. It can move and grow out of the way, which is what we prayed for. We
Mhm.
went to like special healing masses. We got special prayers
Mhm.
prayed,
Mhm.
special blessings to really try to see what we could do to have that placenta move out of the way. And so
Mhm.
it never grew out of the way. So we knew going in that I would have to have a C-section,
Mhm.
probably around, um, 37 weeks,
Mhm.
38, 39, depending on how far
Mhm.
I could go. And really the biggest concern of my OB at the time was just hemorrhaging, which is a classic presentation of a previa. You have
Mhm.
hemorrhaging. So when I was about, I think, 34 weeks and a couple
Mhm.
of days, I had woke up in the middle of the night, had hemorrhaging, had to wake up my husband. We kind of had to decide right away to go to our local rural hospital instead of making the drive up to the big hospital. That's about
Mhm.
45 minutes away with us with a NICU. And so, really, just kind of knowing that that could happen, and we were kind of oblivious. We didn't think we'd have hemorrhaging, or kind of have my life and our daughter Margaret's life kind of be there in the balance.
Mhm.
Um, but anyways, we were able to make it after significant bleeding at home. We were able to kind of wrap up, get into the car, present to the emergency room to the shock of the ER doctors there and the ER technicians, and they kind of whisked us away to an emergency C-section, which thankfully where I live, there was only one doctor locally that can perform emergency C-sections. He was called in and was really great, Dr.
Oh.
Beatty, where we live. So I'm just very thankful for the
Mhm.
team that was
Mhm.
able to deliver her. She was premature, so she was small, 5 pounds, but that is actually big
Oh.
for a preemie.
Oh.
Um, and really during the whole experience, we just really felt God's providence over us. She
Mhm.
had a lot of connections to the number 3, so we really felt like the
Hmm.
Trinity was interceding for us, which is really beautiful.
Okay.
As we look back at the experience, right, it was very emotional and traumatic
Yeah.
going through it, but hopefully, sharing this story,
Mhm.
I don't know. We hope to kind of inspire people and give people just some confidence and hope if they are, presented with kind of the same situation. But
Mhm.
she was
Mhm.
born in June on the 12th. Um, and her NICU room was room 3. She was only intubated for 3 days.
Oh.
Her middle name is Lily, and that's kind of considered a 3-petaled flower.
Mhm.
Um, anyways, we have like a long list of all these 3 occurrences, whether it was due to
Right.
like her medical care or situations around her birth.
Mhm.
So again, we just feel that God really covered us. Even though it was a
Mhm.
scary situation, we were able to
Mhm.
kind of walk through it
Right.
and just really lean, on our faith as well as oh, she was in the NICU for 21 days. That's another, multiple of 3 there.
Mhm. Mhm.
But coming out, leaving the NICU, so she was there for about 3 weeks. Leaving the NICU, we knew we wanted to change our NFP plan. Just having that traumatic birth, we wanted to kind of do everything we could to just have a space of avoiding pregnancy to really breathe,
Mhm.
process
Mhm.
um, our shared experience through that. And then also, give a little bit of space since I had a C-section to
Mhm.
really give it the best shot to have a VBAC in the future. Just
Okay.
because the recovery from a C-section is a lot more difficult. And I
Sure.
had another 3. I'd lost 3 pints of blood,
Oh, wow.
during it. We wanted to give my body time to heal. So
Sure.
we talked about it together. We'd used the cervical mucus method Creighton before, and we really felt like we wanted to switch to Marquette. So we were able to find instruction through a Marquette instructor locally to us. And I bought the monitor and everything, and we really kind of leaned into that. So if my story can really be inspiring to other people, it's just to kind
Right.
of trust
Yeah.
your husband and or your wife in that process of change, because that was really difficult for us to really
Mm-hmm.
trust each other, trust the equipment, and say, okay, it is our intention to avoid for a season. We're going to change kind of our method, and how can we really trust our training in that method and switch to
Yeah.
something new,
Yeah.
while still, cultivating intimacy in our marriage and being open to that. So, but we did switch to Marquette, and we really liked it because it felt very objective.
Mm.
And like we had just a little bit of an extra layer of control, if you will.
Mm-hmm.
So it really was a huge blessing to
Mm.
even have the option to switch, because I
Right.
know in, maybe previous generations, they didn't really have multiple options of NFP, but
Sure.
it was a huge
Sure.
blessing.
Yeah. And I bet this experience has really helped you have that another level of empathy and understanding for women who are going maybe through a similar situation or even maybe not so similar, but just, having that experience. Do you feel like that could help you relate even better to your clients?
I agree. I think so. It's really helped me have more empathy and just slow down and listen to my patients,
Mm,
whether they've
mm-hmm.
had a traumatic experience.
Right.
Even some of my infertility patients have experienced trauma just in their journey of infertility with seeing
Mm,
other providers. I've had several patients kicked out of their local, obstetric and gynecology practices, or um, just had really bad run-ins with other providers where
gosh.
maybe they're just requesting some extra lab work, and the other provider will refuse to order that for them, and they feel stuck.
Mm,
Um,
yeah.
so at my Catholic
Goodness.
doctor, I feel really blessed to be able to take the time to,
Sure.
lean into an appointment and listen, and,
Sure.
acknowledge those feelings, because we
Right.
experienced just such heightened
Mm,
emotions of,
mm,
anger and frustration and sadness over, well, why did this happen to us? Thankfully,
right.
nothing really catastrophic went wrong.
Mm-hmm.
But yeah, we're really able to do that. And then,
Mm-hmm.
I can take it to prayer too, and really intercede for my patients too,
Mm,
just because
yeah.
I know what that feels like to go through that trauma and not really have
Sure.
answers.
Sure. Sure. So, talking about women's health issues, why is it important to find a root cause for those health issues as opposed to like what's usually prescribed in a doctor's office?
Yes, great question. So my FIM training, so FIM is fertility education and medical management. A lot of your listeners might be familiar. They have an NFP branch as well as kind of a medical branch. I like to explain to my patients, and I really like to work on the medical side, um, because when we're able to find root cause, we really bring better health to mom, but also to her baby or babies in the future. And we know
Mm-hmm.
that those changes really trickle down into grandchildren. Um, so we feel like by doing the hard work and finding root cause, and we're pretty tenacious, like we want to find it.
Yes.
So we love like lab work and imaging and really kind of digging into health and wellness and
Mm-hmm.
lifestyle, as well as
Mm-hmm.
medication options. But we know that those changes, when we balance mom's hormones or fix her
Mm-hmm.
metabolism,
Mm-hmm.
her baby and her future babies really benefit from that. And then in those female babies, her grandchildren are going to benefit from that. And even
Mm,
if she has sons, like those future children will benefit from that as well.
sure.
So those changes are part of the field of epigenetics for anyone interested. And it's just very rewarding to kind of feel like we're making generational change
Right.
after
Right.
maybe the way medicine's been practiced since the 60s, since the invention of oral contraceptive pills. We really feel like women have kind of been like medicine stopped listening to women and really stopped fighting for them to have an answer to a lot of their
Mm-hmm.
symptoms and really
Mm-hmm.
get true resolution
Right.
instead of just a band-aid.
Yes.
So it's very rewarding and very exciting to kind of
Right.
practice in this new field. We call it restorative reproductive medicine because we want to restore kind of optimum health to the
Right.
mom. And we also are working to restore ovulation in a lot of our, PCOS and infertility patients.
Mm-hmm. So, how does a woman knowing her fertility cycle and possibly, using a fertility awareness-based method, how does that help her find or get to a root cause of some of the issues she might have?
Yes, I definitely think charting is just one of it helps me see patterns. So if
Mm-hmm.
I can look at a patient's charts, I can kind of discern patterns. And even if she is just giving me data from the chart, that's even helpful too. Total cycle length, length of menses, characteristics of bleeding, how long is her luteal phase, how long is her follicular phase,
Mm-hmm.
is she even having mucus buildup, things like that,
Mm-hmm.
spotting around ovulation, brown bleeding? Those are all kind of things I look for.
Right.
And it's really a starting point.
Mm-hmm.
So I start there. I start with collecting symptoms. I really just try to listen and look for patterns.
Mm-hmm.
And those patterns really kind of direct my workup, if you will, to kind of we call it a differential diagnosis in medicine to really kind of consider what things I should put on that based on, is their cycle too long? Is it too
Mm-hmm.
short?
Mm-hmm.
Is she not ovulating at all?
Right.
So it's crucial, definitely.
Mm. Do most women who come to you, are they already charting, or do you sometimes have to start kind of from the beginning with them?
Yeah, I would say both. We're getting a lot more patients that aren't charting, so we kind of have to
Mm.
go back and start, from square one, saying, hey, it doesn't matter what NFP method you use or which
Right.
app you chart in. Really,
Right.
if you can just start to look at your cycle, maybe throw in checking some temperatures, or even just
Mm-hmm.
starting to observe with cervical mucus,
Right.
anything.
Mm-hmm.
Um, is helpful for us. And it's always great when I get regular charters and ets patients because they already have the data for me and they can send
Right.
over their charts, and I can take a look at them myself.
Right.
Yeah, we're getting lots of, maybe because the word is spreading about NFP and fertility awareness, we're just really kind of getting patients at square one.
Okay. So, just from the different interviews I've had, it just seems like having that chart and as many symptoms as they can, record in that chart, that kind of is like a great baseline
Yeah,
for women.
definitely.
Have you, I don't know how many, male patients that you've had, but have you seen an increase in male infertility over the years? Is that something that you're aware of?
Yes, definitely. Our field is reporting more on an increase in male infertility. I
Hmm.
don't remember exact specific statistics, but we do know that men's semen parameters are changing, so they are going down in number and quality.
Oh.
So that's something. And then also physiologically, so hormones, we know that
Hmm.
men's testosterone is also going down from all the
Hmm.
estrogens like in our water sources,
Oh,
and
right.
different, kind of lifelong chemicals that are used in like pesticides in agriculture. That's
Mm-hmm.
very well documented. So yes, I
Right.
would say I am getting more male patients. As I kind of talk to my female patients, saying it is important for both of you to be worked up.
Mm-hmm.
And then as a field, we've really kind of noticed a lot more male infertility. And maybe that's just because we're looking for it too.
Can you explain what preconception counseling is? And do you have many couples who are seeking this information?
Yes, so I don't have too many, but for the ones that do present for preconception counseling, a lot of them have kind of long-term chronic diseases that they're
Mm.
negotiating, whether that's
Okay.
PCOS, and they were told in their teenage years that they'd never be able to conceive, or
Mm.
maybe it's a special case of like type 1 diabetes or
Hmm.
hypertension, like something more chronic. But when they present, we kind of talk about, okay, so it takes two to make a baby. We want optimum health for mom. So we start there. We'll look at charting. I look at some lab work, imaging, really try to work with our primary care providers to optimize the care they're receiving, for their chronic diseases. If it's anything female health related or fertility related, I kind of take over care of that.
Okay.
And then, we do the same thing for men. So if they're open to it, we'll kind of do some basic lab work and imaging there to just to kind of map out any potential pitfalls, and we'll kind of walk through, okay, here's how you identify your fertile window. Here's kind of the latest and greatest in terms of teaching for, trying to conceive, as far as how many days to have intercourse in the cycle and when and how to target, that kind of thing. And then if we see any red flags, I'm kind of coaching them through the decision, kind of laying out pros and cons of whether to continue to be open to life or to kind of take a break, and maybe go through a season of avoiding so that we can get one or both of their health optimum, so that we can lower the risk of miscarriage, or any kind of abnormalities that could happen.
Sure. You mentioned PCOS. Do you feel like that is a more common issue for women now? Do you see it more in your practice?
Yes. So I have a large number of PCOS patients in my practice. It's probably the most common endocrine and metabolic condition that women present with. And there's actually, which Betsy might have talked about this, but she's pretty passionate about it too. There's kind of 4 phenotypes of PCOS. And so we're really kind of seeing all 4 different types, which is really interesting. And really we're contributing it to just changes in nutrition, as well as changes kind of passed on from moms, being exposed to oral contraceptive pills, or just the chemicals that have really occurred in the later 20th century as well as the earlier 21st century. And those changes get passed down, to babies. We know that baby girls are really affected by the hormone balance in utero that mom is presenting, in the placenta as well as in the amniotic fluid. So it can be really difficult to trace it back. But yes, we're seeing more. And fortunately, we have, better tools to really treat it.
Just out of curiosity, how long do those chemicals stay in a woman's body? Like, do you recommend, like, if somebody has been using contraceptives, that they wait for a certain amount of time before conceiving to kind of clear that out of the system? Is that doable?
Yeah, that's a great question. Oftentimes, if there's a period of waiting, I'm giving the advice of about 71 days, because we know that part of folliculogenesis, or the development of the follicle, takes 71 to 72 days. So, almost 3 months, right, of waiting, and then kind of reobserving or retesting lab work to see if things, have cleared out. But even yesterday, I got a call from someone who had stopped, progesterone mini pill and was very concerned that she hadn't started her cycle yet, but really she was on the cusp of kind of that 70, 71 days.
Okay.
So, I was able to kind of provide that, and say, okay, that can be normal. It can even take longer for cycles to come back too. But it is really helpful to let those hormones kind of rebalance, just so you have the best follicles develop and the best quality ovulation you can have, right? And for the highest probability of implantation and a healthy baby, healthy pregnancy. So
Right. So in about that 3-month period, the woman's cycle can come, back to a healthy rhythm, and those chemicals have pretty much cleaned out of the system, and things are a bit safer.
Yes.
Okay. Interesting. Well, it's good that it's not any longer.
Yes, even 3 months it's really hard emotionally for my patients to even get that advice. So
Yeah, to wait that long. Yeah. Oh gosh. So, how can knowing your cycle and possibly using a natural family planning method, how can that help a couple achieve and postpone for a woman who does have PCOS?
yes, another great question. I think it's a great tool. It really helps women with PCOS who we know typically have an ovulation dysfunction. That's one of the characteristics of PCOS.
Mm-hmm.
Really helps them target and identify their fertile window, because that follicular phase in the beginning tends to be rather long for patients with PCOS. So
Mm-hmm.
it can really help them have less anxiety to be able to say, okay, it's going to happen. My fertile window is going to happen, but it's a little longer than maybe the standard advice that's given, in
Right.
books or on popular blogs or podcasts. To really lean into that,
Mm-hmm.
and identify the fertile window and really time intercourse. It's very helpful. But
Right.
even tracking their symptoms can be helpful for us to kind of maybe see what kind of hormonal imbalance that they're experiencing too, to really kind of
Mm-hmm.
intercede and make changes, whether that's trying some medication if they need it, or
Mm-hmm.
trying supplements or lifestyle changes, with diet and exercise. I just think it's crucial, not only for the conception part, but even just monitoring health.
Mm-hmm. Mm-hmm. Does having had a baby and delivered, does that seem to lessen symptoms of PCOS, or does it tend to just ramp back up again after a delivery?
I've seen both. So I have seen women kind of have a relief from their symptoms, and then I have also seen it kind of come back with a vengeance.
Mm-hmm.
So again, after uh, maybe a woman delivers, I'll monitor and kind of stay in communication through the postpartum period just to provide that postpartum support, make sure
Mm-hmm.
they feel confident in their postpartum NFP practice. And then whenever they
Mm-hmm.
start cycling again, we can pull some blood work, kind of see where
Right.
things are at. With
Right.
PCOS,
Right.
we're really worried about high androgens. So those, male hormones, but females have them too.
Mm-hmm.
They
Mm-hmm.
can run higher in women with PCOS. That's another hallmark symptom. So we want to make
Mm-hmm.
sure they're not too high.
Okay.
We want to help her kind of really rebalance things,
Mm.
postpartum. Then the
Sure.
other hallmark of PCOS is really metabolic imbalance, so insulin resistance. And really, a theory is that PCOS is really just insulin resistance at the ovary, so that the ovary and the brain can't communicate signals very well. And the stimulation of insulin over time really creates a lot of those little tiny follicles that build up.
Oh.
So working to really, you know, bring glucose down, bring insulin
Right.
down through
Right.
achievable lifestyle
Right.
change.
Mm-hmm.
Intermittent fasting is a really helpful tool, but most
Mm-hmm.
women can't really intermittent fast because we're either breastfeeding a baby or we're pregnant or all these things. So
Yeah.
really working to, which all those nutrition and lifestyle coaches out there are so great at this, like
Mm.
looking at a food diary, lowering the amount of carbs, and really kind of working on building up a
Mm-hmm.
really good nourishing tradition to, rebalance insulin and glucose in our PCOS patients.
Mm-hmm.
Yes.
So let's talk about women who are, perimenopause, menopause. So hormone replacement therapy, it's had a bad rap for a long time. What is your practice when it comes to HRT for perimenopause or menopausal women?
Yes, it has had a bad rap.
Mm-hmm.
I really rely on the FEM protocol for HRT. So we really start with trying to find any sort of root cause that could be causing hormonal imbalance before we start HRT.
Mm-hmm.
So I really love to check the thyroid, make sure it's functioning appropriately by checking a full thyroid panel. So that can be something even patients can ask like their primary care provider for if they don't have access to fertility care. I also like to check, glucose and insulin. So fasting glucose and fasting insulin to make sure metabolism looks good. Check a lipid panel to make sure, that can give a better picture of metabolism as well.
Mm-hmm.
Check some other things like high prolactin. So sometimes women have that. It's made in the brain and it can be functionally elevated and really just suppress ovulation and suppress the ovary because it makes your body think you're breastfeeding when you're not. We want women to have that hormonal balance of estradiol, progesterone, and
Right.
testosterone for as long as is a physiologically appropriate, for their
Sure.
body. So kind of checking root cause, see if anything's there. And then
Mm-hmm.
if we can't find anything, kind of moving forward with presenting the information so they can make an educated decision.
Mm-hmm. Mm-hmm.
And we also want to coach women through considering, okay, if you've had any kind of breast cancer, ovarian cancer, endometrial cancer, pretty much rules out hormone replacement therapy. Then we kind of walk through,
Okay.
stroke risk, blood clotting risk. Even they're starting to say women who have migraine with aura, so kind of that visual disturbance before a migraine, might need to not consider HRT just because of an increased risk they've found for those patients having strokes. So I really like to say that nobody needs HRT. No one has to have it, but you can make an informed decision if you would like to try it for relief, from just those troublesome like perimenopause symptoms.
Right. Wonderful. So how did you get connected with My Catholic Doctor?
Yes, that's a great story. I was actually in PA school, and so I listened to Catholic radio on my phone because I live in the South and we don't have Catholic radio live on our radio system. But I would listen to Sacred Heart Radio on my phone, and I heard My Catholic Doctor having like advertisements on there, as well as Dr. Berschelman, Kathleen Berschelman, was interviewed by the host talking about Catholic healthcare, how My Catholic Doctor was launching back, I'm not sure the exact date, but around probably 2016, 2017 was when I was hearing that. And I really got excited and thought, wow, this could be like, I'd love to practice Catholic medicine on a Catholic platform as someone who is Catholic. Really being able to attest to my faith and practice medicine within the bounds of my faith was just huge. I ended up reaching out after I graduated from PA school in 2019 saying, I'd love to practice. Is there any way I can join? And at the time, the timing wasn't right because they didn't have anyone who could be my supervising physician because all PAs work collaboratively with a mentor, a supervising physician. So it wasn't the right timing. I ended up practicing in geriatric internal medicine through all that. And then kind of after 2020 and after the birth of our second daughter in the fall of 2020, I left medicine for a little while and really connected with some other of my colleagues in restorative reproductive medicine, asking questions, asking, hey, I have this goal, I have this desire, I'd love to practice medicine this way, how can I do it? And again, I was just pointed to My Catholic Doctor. I reconnected with Dr. Berschelman, and she was fantastic. At that time, she really helped me join the community at My Catholic Doctor, and we worked together to find a supervising physician in my diocese that could oversee, and work with me, which was fantastic. And really, we've just grown like leaps and bounds since then.
Right. So, Couple League has the Fertility Science Institute directory for providers such as you, who are Catholic, want to practice, in a faithful, moral, ethical way. So that's the FSI directory is a great place for all of you to be, connected and in one place for somebody who's needing somebody like you to find. And then you've got My Catholic Doctor, which is a platform for all of you to practice. How important is that to have those kind of platforms or resources, like for you personally and for your patients?
Yes. I mean, I personally have relied on them as someone who was looking for fertility care, kind of in those newlywed years. Who can I establish care with? Who is out there? So having those lists, I think, are huge. It is a resource for patients to really find someone to advocate for them because the standard medical system can be very difficult to navigate. Sometimes I'm able to coach my patients as far as, kind of go in, know what you want, know your no's, and be okay, pushing back against some of the care you don't want to receive, which is okay. But it can be really difficult. It is difficult for me as a PA going into the hospital or another, OBGYN or even pediatrician and really pushing back against that care. But just having the confidence to know that, okay, there's other providers out there that I can see, I can refer my patients to, is huge. And we get to increase our field of medicine, restorative reproductive medicine, and just get the word out there because we just want to help as many people as we can.
Sure. Yeah. So Megan, thank you so much for being on the PeakDay podcast. It has been wonderful speaking with you.
Thank you so much for having me. It's been great.
Great.